So I'm going to push you guys a little further. So the first product you mentioned, Voxelotor, that was in the HOPE trial, when I asked you about who you'd like to see it in, you basically said as many people as possible, right? And yet we talked about, you know, the good results that can be achieved by what's out there if we get the compliance, right? So I'm asking my payers, do we try to push compliance before we open up access to new medication? Does this become a prior authorization process, a step process? Like, how do you look at that when there's an old, effective generic on the market?
Well, I also heard that the study was done on top of hydroxyurea.
Right. Yeah, right.
So I don't think we can just forget hydroxyurea and its benefits. Again, as per the clinical trial, in a center of excellence that is comfortable with the use of hydroxyurea, how do we maximize that potential? And then with that, of course, add to that if there's intolerance issues, then I think we have to think about what is the potential for this drug as monotherapy. But optimally, you'd want a patient on hydroxyurea.
And we recognize that these are not replacements to any current therapy. They're probably going to be add-on or combination. But the exciting thing is that it treats the disease upstream, as opposed to just being reactive and treating symptoms or manifestations of the progression of the disease. Now we have a chance to actually alter the course of that disease progression.
So that was the answer I was looking for, but it brings up the follow-up question, which is, and this is something we face in other disease states, right? You have drug A, and drug B is an add-on to drug A, and a lot of people stop taking drug A. Do you continue to cover drug B? Or if it's combination therapy, do you only cover it in combination?
We would cover both.
You would cover it?
Yeah, we would not. I mean, because that will become the treatment guideline. And so it wouldn't make sense for the payer to say, no, we're only going to cover one or the other. So,
oh, no, what I'm saying is if the patient had to be on hydroxyurea to get to Voxelotor,
oh, no, because
would you only cover them if they were used in combination?
I think the clinical trial showed patients that were on, but I think it also included, or maybe there were patients also that were not on hydroxyurea, and they had similar significant impact. So, and not every patient is able to tolerate, not every patient responds to hydroxyurea, but we would cover both.
So you would have to do it as a
That's right, yep.
I think we'd probably have language there that would suggest that you have been or are intolerant to hydroxyurea. And again, in line with guidelines or the standard of care, and we would certainly make sure that the prior authorization was in line with the thought leader specialty in terms of their approach, but there may be some language in there that gives an out, but yet reinforces the option of hydroxyurea.
And realizing that we don't have all the data yet, right? I'm not. You know, if you're talking about a medication that's there as pain prophylaxis, what's the population for that? And is it something that can be reserved for patients with more severe chronic pain or patients who are going through a crisis? Like, where could you draw parameters?
Sure. As far as that drug goes, the crizanlizumab drug that we're discussing, for now, it definitely is a pain medication. The phase 3 trial is going to look at multiple different effects that it may have beyond pain. So we'll see if the indication sort of broadens in the phase 3. I do think that you would reserve, crizanlizumab for patients who are quote-unquote frequent flyers, or patients that are starting to have pain episodes despite hydroxyurea, or patients who are sort of really struggling with staying out of the hospital, having a very tremendous decline in their quality of life. I think each clinic would have to make that decision on a patient level.
Is that something you would put a prior authorization or criteria on?
That is possible, but I think it's a great opportunity for an outcomes-based approach. Yeah. That if they can reduce the number of pain episodes that result in a hospitalization or ED visits, then we would probably entertain that discussion with the manufacturer.
Right.
I think if it started in the hospital, and it's allowed to then be continued, that's usually an easy prior authorization to fulfill. It becomes more of a transition in care opportunity. Where's the patient after the post-acute going to receive the infusions? How can we connect with the patient, continue to make sure because again, it is IV, so the good news is we know it was given or not. The challenge may still be the compliance to be able to get to that site, to be able to
Absolutely.
ensure compliance.
And I think we have to understand is that's what's driving my medical costs, is that ED presentation or hospitalization due to pain crisis. And so I think the patient community as well as the provider community is going to be interested in that because of the pain.
So Maria brought up a term earlier that has become sort of pervasive in the industry in terms of what we're looking for. And she said disease modifying, right? So realizing not all the data's in, right, just what we know in the pipeline, from your clinical perspective, do you suspect any of these could actually be disease modifying?
I do. I absolutely do. I'm very excited as a provider for sickle cell patients. Again, in a field where we really have not had anything to offer, suddenly we're going to have all of these amazing options. I feel like each sort of medication that we discuss, particularly the first two, voxelotor and crizanlizumab, are really going to be game changers. I really do feel strongly about that. And I think that they will truly make a mark on the footprint that sickle cell currently has in the United States. I have a lot of excitement at this point in time for both agents.
And that opens up the channels for you, correct?
Oh, absolutely. Yeah, and if indeed, isn't that our goal, to reduce crises, to
Absolutely.
reduce hospitalizations and ER visits?